Imagine for a second that you notice this crack spreading across the drywall in your living room.
Right, like a stress fracture.
Yeah, exactly. And your immediate instinct might be to just run down to the hardware store, grab a bucket of really expensive high-end paint, and just, spackle right over it.
Which, I mean, visually, that looks fantastic for, what, a week or two.
Right. But what if that crack isn't just a cosmetic flaw? What if it's the main load-bearing beam of your house starting to buckle? You wouldn't just paint over a collapsing foundation.
You certainly shouldn't know. Yet, when we look at current trends in women's pelvic health, we are seeing this massive wave of patients and providers essentially doing just that, painting over a structural collapse.
Yeah, it's wild. We have this rapidly expanding cosmetic industry colliding directly with foundational pelvic anatomy.
And that collision is exactly what we're exploring today.
Which brings us to the mission for today's deep dive. Welcome, by the way. We're looking at a huge stack of global clinical guidelines from groups like the Royal College of Obstetricians and Gynecologists, various urogynecology societies, and even international warning statements from the FDA.
It's a lot of data.
It is. But the central issue dominating all these reports comes down to one really urgent question. And that is, should a surgeon comprehensively assess a patient's vaginal support structure before trying to cosmetically tighten the tissue, especially after she's had a hysterectomy?
To give you the short answer, right out of the gate, absolutely. Yes. Bypassing a structural assessment for a quick cosmetic fix isn't just, ineffective. It can actually leave severe, debilitating mechanical failures completely undiagnosed.
So to understand how we got to a place where international health authorities are actually issuing warnings, we kind of have to look at the trend itself. I keep seeing these ads online for clinics and med spas offering something called vaginal rejuvenation.
Oh yeah, those are everywhere right now.
Right. They show these sleek little wands and promise a quick non-surgical fix for laxity or looseness. What are these clinics actually doing?
Well, let's start with that phrase. Vaginal rejuvenation is not a medical diagnosis. It's not an anatomical term at all.
So it's just marketing.
Purely a marketing buzzword. The American College of Obstetricians and Gynecologists notes that this umbrella term covers a really wide array of elective procedures. What you're seeing in those ads, mostly, are energy-based devices, or EBDs.
EBDs, okay.
Yeah, these are machines that utilize either fractional CO2 lasers or radio frequency energy.
I've definitely seen some of the brand names floating around, usually something with like Lift or Empower in the title. But how does a laser wand translate to tighter tissue?
It relies on controlled thermal injury. So if we look at a fractional CO2 laser, for example, a clinician inserts a specialized wand into the vaginal canal. And this wand emits these highly targeted pulses of heat.
Okay.
But the critical detail here is the depth. That laser energy typically only penetrates about 0.5 millimeter into the vaginal mucosa.
Wow, just 0.5 millimeter.
Just 0.5 millimeter. It essentially vaporizes tiny, microscopic columns of tissue, creating thousands of pinpoint thermal wounds.
That sounds kind of aggressive. Actually, it makes me think of aerating a lawn. Like when a landscaper punches those tiny holes into the compacted dirt, it stresses the grass just enough to force the underlying roots to, wake up and grow back thicker.
That is a brilliant way to visualize it, yeah. The micro wounds from the laser trigger the body's natural healing cascade in the untouched tissue right around each pinpoint.
So it's triggering the body into healing itself.
Exactly. The thermal energy acts as an alarm bell for specialized cells called fibroblasts. And when fibroblasts are activated by heat, their primary job is to synthesize structural proteins. So they begin mass-producing new collagen and elastin fibers, which is a process called neocollagenesis.
And more collagen obviously means plumper, more elastic tissue.
Right. And beyond just collagen, the heat also triggers neovascularization, which is literally the formation of entirely new microscopic blood vessels. And more blood vessels mean better circulation, better hydration.
Okay, let's unpack this, because if someone is dealing with superficial issues, this aeration process sounds pretty effective. Who is the ideal candidate for this?
It really shines for patients dealing with genitourinary syndrome of menopause, or GSM.
Right, because of the estrogen drop.
Exactly. When a woman goes through menopause, her estrogen levels just plummet. And estrogen is essentially the fuel that keeps the vaginal lining thick, moist, and elastic. Without it, the tissue undergoes atrophy. It becomes paper-thin, dry, inflamed, fragile, making intimacy incredibly painful and increasing the risk of infections.
I can completely see why a treatment that forces the body to rebuild its own collagen and blood supply would be a total game changer for menopausal atrophy. It's kind of using the residual water in the tissue to spark a natural rebuilding process.
It genuinely improves quality of life for those specific surface-level mucosal issues. But notice the limitation we established earlier.
The half-millimeter thing.
Yes. The laser penetrates half a millimeter. It is strictly altering the superficial lining. It does not, and really cannot, reach or repair the deep, complex, muscular architecture of the pelvic floor.
Which brings us right to the danger zone, right? What happens if the problem isn't sitting in that top half-millimeter? I mean, if a patient walks into a clinic complaining about a feeling of looseness or maybe even a physical bulge, she might think she just has stretched out tissue.
Which is a very common assumption.
But if she's had a hysterectomy in the past, those symptoms might point to something much more severe, like vaginal vault prolapse.
Right. And to grasp why vaginal vault prolapse happens, you really have to completely reframe how you think about the uterus. People tend to think of the uterus simply as, a vessel for carrying a pregnancy. Mechanically, however, it serves as the central anchor point for the entire upper pelvic floor. The top of the vaginal tube is firmly attached to the cervix and the uterus. And the uterus itself is suspended from the pelvic side walls by these thick, incredibly strong connective tissues, like the uterosacral ligaments.
It sounds almost like the center pole of a large circus tent holding the whole canvas up. And when a woman has a hysterectomy, that center pole is surgically removed.
That's a great mechanical comparison. So during a hysterectomy, after the uterus is removed, the top of the vaginal tube, which we call the vault, is stitched closed.
Okay.
Now, the surgeon typically tries to reattach the top of that closed vault to the remaining ligaments to maintain the suspension. But if those ligaments were already stretched from, say, past childbirths, or if the tissue degrades over time due to aging and estrogen loss, that suspension can just fail.
So the top of the tent literally caves in.
Literally. The vaginal vault loses its upward support and begins to invert. It telescopes down inside the vaginal canal. And in severe cases, the top of the inside of the vagina can drop so far that it actually protrudes outside of the vaginal opening.
Oh, wow. The physical reality of that sounds profoundly difficult to live with. What are patients actually experiencing day to day when that architecture collapses?
It alters everything. The clinical guidelines describe patients suffering from a constant dragging pressure in their pelvis, a feeling like their insides are literally falling out. Just standing up for long periods becomes exhausting.
I can't even imagine.
But the mechanical domino effect is perhaps the most distressing part. Because the vagina has lost its structural rigidity, the organs next door start to cave in as well.
Wait, meaning the bladder or the bowel?
Yes, the rectum sits directly behind the vaginal wall. If that wall weakens and prolapses, the rectum can bulge forward into the vaginal space, creating this hernia-like pocket called a rectocele. And when a patient with a severe rectocele tries to have a bowel movement, the stool gets trapped in that forward bulging pocket. To actually pass the stool, some women have to insert their fingers into the vagina or press really hard on their perineum to physically push the rectum back into place.
To physically push it back.
Yeah. That maneuver is medically known as splinting.
Splinting. Wow. That paints a very stark picture of just how mechanical this failure is. We are talking about organs literally losing their geographical boundaries.
Exactly. And we also see the bladder bulging backward into the front vaginal wall, which is a cystocele, causing severe urinary retention or incontinence.
So if we bring this back to the med spa and those laser advertisements, a woman is experiencing this heaviness. Maybe she feels a physical bulge, and she attributes it to just laxity. She books a 15-minute non-surgical laser tightening appointment. She is essentially taking a device meant to treat half a millimeter of tissue and dragging it across a massive multi-organ hernia.
It is scientifically illogical. This is exactly why medical authorities are sounding the alarm. Treating a vaginal vault prolapse with a fractional CO2 laser is it's like trying to fix a broken axle on your car by applying a fresh coat of wax to the hood.
Right.
A laser works on cellular water to stimulate collagen. It cannot sew a disconnected uterosacral ligament back together. It cannot close a hernial portal, allowing the bowel to trap stool.
Which perfectly answers the core mission of our deep dive. A surgeon or clinician must assess the underlying support before doing anything cosmetic. In fact, the sources include this really direct quote from Vivek Nama, a consultant gynecologist.
Yes, I read that.
He says a physical examination to identify pelvic floor abnormalities is an absolute prerequisite to any laser treatment.
He is quite firm on that point, noting that while their clinic uses lasers for moisture and atrophy, they absolutely do not treat significant pelvic floor abnormalities. You just cannot laser away a prolapse.
But how does a doctor actually map out a collapsed tent? If I go in for an assessment, they aren't just taking a quick look with the speculum, are they?
No, a standard visual exam is totally insufficient. The gold standard diagnostic tool required by urogynecologists is called the POPQ system. That stands for pelvic organ prolapse quantification. It is a highly rigorous, standardized measurement protocol.
I read the breakdown of the POPQ in the clinical guidelines, and honestly, it felt like reading instructions for a surveyor mapping out a canyon. They're essentially creating a topographical map of the internal anatomy.
A topographical map is the perfect way to describe it. To measure anything, you need a fixed 0 point, right?
Mhm.
In the POPQ system, the hymenal ring serves as sea level.
Okay, sea level.
The clinician uses a ruler to measure 6 specific points in the pelvic floor relative to that sea level. Anything sitting above the hymen inside the body is recorded in negative centimeters. Anything bulging past the hymen out of the body is recorded in positive centimeters.
So they aren't just saying, hey, you have a prolapse. They're gathering really precise mathematical data.
Down to the half centimeter. And they take these measurements while the patient is performing a Valsalva maneuver, which means bearing down or coughing with maximum force.
To see it under stress.
Exactly. They need to see the architecture under extreme stress. They measure point C, which tracks the exact location of the vaginal cuff scar left behind from the hysterectomy. If point C is dropping to a positive number, they know the vault is collapsing. They measure point B to see if the front wall is caving in from the bladder.
It really removes all the guesswork. But the sources also highlight that topography only tells you what has already fallen. To understand why it fell, clinicians are increasingly relying on 3D and 4D translabial ultrasounds. What exactly are they looking for beneath the surface?
They're looking for hidden structural trauma, specifically in the levator ani. The levator ani is this broad, bowl-shaped complex of muscle that forms the true floor of the pelvis. Using high-resolution ultrasound, clinicians can visualize these muscles dynamically. They are specifically searching for levator avulsions.
An avulsion means the muscle has actually been torn off the bone, right?
Correct. It is a severe mechanical detachment of the muscle from the pubic bone, almost exclusively occurring during traumatic vaginal childbirth, particularly with forceps deliveries.
Here is something that really caught my eye in the research, though. A woman might suffer that avulsion during childbirth in her early 30s, but she doesn't actually experience the vaginal vault prolapse until decades later, well into her 50s or 60s, often after a hysterectomy. Why is there such a massive delay?
It comes down to compensation and the protective effects of estrogen. In her 30s and 40s, a woman's body has enough tissue elasticity and surrounding muscle strength to compensate for that localized tear. But then two things happen.
Menopause and a hysterectomy.
Exactly. She enters menopause, which strips away the estrogen, causing the connective tissues to dramatically thin and weaken. Then she undergoes a hysterectomy, which removes the central ligament anchors.
So the remaining support structures are suddenly asked to bear the entire load without the help of the uterus, and they just give way.
The decades-old mechanical injury is basically unmasked by the new hormonal and structural reality. And this delayed latency proves why skipping an ultrasound in a POPQ exam is so incredibly dangerous. A clinician armed only with a laser wand has absolutely no idea that the patient's levator muscle is detached from her pubic bone.
It's scary. And the disparity between what patients actually need and what some cosmetic clinics are selling has triggered a unified and honestly quite stern regulatory response. The FDA in the United States, the Therapeutic Goods Administration in Australia, and the Royal Australian and New Zealand College of Obstetricians and Gynecologists have all issued formal warnings.
The language across these international bodies is remarkably consistent too. The FDA stated they have deep concerns about energy-based devices being marketed to treat major gynecological conditions, noting that these applications are entirely outside their approved scopes.
The Australian TGA actually initiated a post-market review because they realized there wasn't a single device approved specifically for the marketing term vaginal rejuvenation.
Right.
The overarching theme of all these warnings is deceptive marketing. Clinics are targeting vulnerable patients who are dealing with the frightening, exhausting symptoms of prolapse and selling them expensive, unproven cosmetic packages instead of providing a medical diagnosis.
And when a patient pursues a cosmetic laser for a structural prolapse, not only does she lose money, but her actual condition is left to deteriorate. The hernia worsens. The splinting becomes more difficult.
So let's follow the evidence-based path here. Say a patient insists on a POPQ assessment. The urogynecologist measures the descent and confirms, yes, your vaginal vault is prolapsing following your hysterectomy. Since the laser is completely off the table for fixing the structure, what are the actual solutions the clinical guidelines recommend?
The guidelines, such as those from the UK's National Institute for Health and Care Excellence, mandate a stepwise approach, starting with conservative, non-invasive management. The frontline defense is guided pelvic floor muscle training.
And to be clear, this isn't just a pamphlet telling you to do Kegels while you wait at a red light.
Far from it. It is a rigorous, supervised physical therapy protocol lasting a minimum of 16 weeks. A specialized pelvic floor physiotherapist works with the patient to neurologically re-educate the remaining intact muscles. If they can strengthen the surrounding sling, they can often manage mild to moderate prolapse symptoms without surgery.
But what if the vault has dropped too far for muscle training to hold it up? The guidelines point to physical support devices, right? Specifically, vaginal pessaries.
Pessaries are a brilliant, highly effective conservative option. A pessary is a medical-grade silicone device, custom-fitted by a clinician, that the patient inserts into the vagina. Mechanically, it functions kind of like a keystone in a stone archway.
Oh, I see.
It physically props up the vaginal walls, holding the vault, the bladder, and the rectum in their correct anatomical positions.
So it's an internal scaffold. But what if a patient has a grade 3 or 4 prolapse, where the vault is literally protruding outside the body and a pessary just won't stay in place?
At that stage, surgical reconstruction of the suspension bridge is necessary. There are two primary approaches urogynecologists use to restore the anatomy. The first is a sacrospinous fixation.
Okay.
This is typically done vaginally. The surgeon navigates deep into the pelvis to locate a very dense, incredibly stable band of tissue called the sacrospinous ligament, and they physically stitch the top of the fallen vaginal vault directly to it.
So they're essentially installing a brand new anchor point to replace the one lost during the hysterectomy.
Precisely. The alternative is a sacrocolpopexy, which is usually performed laparoscopically or robotically through the abdomen. In this procedure, the surgeon uses a piece of synthetic Y-shaped mesh. They attach one end of the mesh to the vaginal vault and anchor the other end to the sacrum, which is the solid bone at the base of the spine.
Now, I know mesh has been a controversial topic in the past. How does it work mechanically in this specific surgery?
Well, the mesh acts as a permanent artificial ligament. Over time, the patient's own native tissue grows into the microscopic pores of the mesh, integrating it into the body to create a really durable upward suspension system. And when performed by highly trained specialists for vault prolapse, sacrocolpopexy has excellent long-term success rates.
There is one detail in the surgical guidelines that I found incredibly compelling, though. Surgeons can actually intervene to prevent this entire ordeal during the initial hysterectomy.
Yes, through a technique called a McCall-Culdoplasty. While the surgeon is actively removing the uterus, they proactively capture the ends of the uterosacral ligaments and suture them directly into the new vaginal cuff as they close it.
So they rebuild the suspension bridge in the exact same surgery where they remove the main pillar.
Exactly. They don't leave it to chance.
That level of preventative foresight completely underscores everything we've discussed today. The pelvic floor is a deeply interconnected architectural system. You cannot alter one piece without considering the load-bearing consequences for everything else.
And that reality really places a significant burden on the patient to ask the right questions.
It makes you wonder, if you were walking into a clinic tomorrow with feelings of heaviness or a noticeable bulge, your instinct would probably be to just trust whatever slick brochure the clinic hands you. But based on the data we've unpacked, the first question out of your mouth shouldn't be about the brand of laser they use. The first question has to be, are you going to perform a POPQ anatomical assessment?
Because if a provider is willing to sell you a commercial laser package for a pelvic bulge without ever physically measuring the integrity of your ligaments or doing an ultrasound to check your levator muscles, you are in the wrong clinic. You need to seek out a qualified urogynecologist.
We've covered a tremendous amount of ground here. To sort of synthesize the clinical consensus for everyone listening, energy-based devices like fractional CO2 and radiofrequency are remarkable tools for the right problems. By triggering neocollagenesis and new blood flow, they can drastically improve the superficial mucosal lining for women suffering from menopausal atrophy.
They're excellent surface tools, yes, but they absolutely cannot restore lost structural integrity.
And measuring that integrity, particularly after the profound structural shift of a hysterectomy, is the only way to catch a mechanical failure like vaginal vault prolapse. You simply cannot laser a disconnected ligament back together.
True restoration requires addressing the actual mechanics, whether through intensive physiotherapy, a structural pessary, or precise surgical reconstruction.
Which leaves us with something critical to think about as we wrap up. We are living in an era where non-surgical aesthetic medicine is just booming. Med spas offer convenience, zero downtime, and incredibly polished marketing. But as these outpatient laser lifts become more normalized, how do we ensure we aren't abandoning foundational diagnostic medicine? It is so tempting to choose the 15-minute wand over the rigorous, sometimes uncomfortable POPQ physical exam. But as we've learned today, before you spend a fortune painting the walls, you have to be absolutely certain the house is still standing. Thanks for joining us on this deep dive. We'll see you next time.